Hello viewers, welcome back to my channel. I am Puspen Dasgupta, a YouTuber by avocation and an ENT specialist by vocation. In the last 2 weeks, I have uploaded two different videos talking about explain why questions. They have been quite well received, and I have a large database of explain why questions, but it can always get bigger if you provide suggestions from your side regarding which questions I should answer for your benefit. In today's video, once again, I will talk about 5 explain why questions because explain why questions are a part of the theory question paper, especially in MBBS ENT assessment. However, these topics are also important for understanding for anyone who has any interest in ear, nose, and throat. So without further ado, let's get into the meat of the discussion. I hope you will like the video. I don't know about you, but I have always been suspicious of answers that I come across online. So you should be suspicious of my answers as well. Don't take them as gospel. Don't take them at face value. Please verify them from your textbook. I'm trying to provide the best possible answer according to my knowledge. I have obtained an MBBS degree. I have obtained a postgraduate degree, and I'm also a member of the Royal College of Surgeons of England, which basically signifies that I can be perceived as an expert in this topic, but that doesn't change the fact that I am human and I can make mistakes. And please don't take my answers as gospel. If you find any factual inaccuracies, or if you want to comment on the quality of the videos or the lack thereof, then please feel free to do so in the comment section below. I love to learn from you. All feedback is welcome on this channel. So with that disclaimer out of the way, let's get into the first question for today. Weber test is lateralized to worse ear in conductive hearing loss. Explain why. Now, if we know anything about Weber test, then we know that it gets lateralized to worse ear in conductive hearing loss, better ear in sensory neural hearing loss, and does not get lateralized if the patient has normal hearing. However, we have to remember that the terms are worse and better. It is never Weber gets lateralized to diseased ear or Weber gets lateralized to normal ear. So these terms matter. However, I don't want to get into too much detail about this. Let's just focus on this question. If you want to answer this question, we have to briefly describe Weber test. What is Weber test? So a tuning fork is taken. It is made to vibrate by striking against a bony prominence of the examiner, such as the elbow, olecranon process, or knee. And then this vibrating tuning fork is placed on a midline bony prominence of the patient. Okay, so a midline bony prominence can be glabella, it can be teeth, it can be chin. And then the patient is asked if the patient can perceive the vibrations more in one ear or not. Now, in conductive hearing loss, patient will say that the sound is getting perceived more in the worse ear. Why does this happen? So when the tuning fork is placed in the midline, the vibrations are getting transmitted on both sides by bone conduction. Transmission is happening through the cranium. The cranium is an excellent medium for sound transmission. So even in conductive hearing loss, this transmission to both sides remains the same. What is the thing that is different? In conductive hearing loss, air conduction is compromised. So if this was a situation with unilateral pathology, then the side which has conductive hearing loss will have poor air conduction. Now this compromised air conduction produces something which is called occlusion effect. Due to occlusion effect, the perception of sound by bone conduction automatically increases. So you can recreate this occlusion effect by pressing your tragus backwards to occlude the opening of the external auditory canal, that is the external auditory meatus. So occlude the opening of the external auditory canal by pressing the tragus backwards. This also recreates the occlusion effect, and automatically by doing this, bone conduction becomes relatively more. So if you want to answer this question, just write Weber test is lateralized to worse ear in conductive hearing loss due to the presence of occlusion effect in the worse ear due to compromised air conduction produced by conductive hearing loss. If you want a better explanation, a more detailed explanation, I'll provide a link to an article in the description below which describes this phenomena with greater description of the fundamental principles of physics. I hope you will like reading about it. If you have any suggestions to make this answer better, feel free to mention it in the comment section below. Or if you have any doubts, again, feel free to reach out in the comment section below. I'll be happy to get back to you. The second question for today is, Rhinosporidiosis has a tendency to recur and dapsone is helpful to prevent recurrence. Explain why. Again, whenever the questions are asked like this, it's always a good idea to explain some of the terms before you actually get into the answer. So it's a good idea to write what is rhinosporidiosis. Rhinosporidiosis is a granulomatous disease of the nose. It is caused by Mesomycetozoa called Rhinosporidium siberi. Earlier, it was believed to be a fungal infection, but now it is believed to be caused by Mesomycetozoa. Now, rhinosporidiosis has a tendency to recur, possibly due to the spores that might be inadvertently left behind despite surgical excision. Now, these spores can lead to recurrence of rhinosporidiosis, and rhinosporidiosis is notorious for recurrence. So why does rhinosporidiosis recur? Due to the presence of the spores inadvertently left behind after surgical excision. Dapsone is helpful to prevent this recurrence because dapsone prevents maturation of the sporangia. So spores left behind can cause recurrence of rhinosporidiosis, and these spores can be prevented from reaching maturation by dapsone. I hope this answer made sense. If you have any doubts about this answer, please feel free to reach out in the comment section below. The third question for today is, Rini is false negative in unilateral severe sensorineural hearing loss. Again, this is the tuning fork test. Let's describe Rini's test first. Rini's test is performed with 512 Hz tuning fork. Again, this tuning fork is made to vibrate in the same manner as Weber's test. And now in Rini's test, air conduction is compared with bone conduction. How does this comparison happen? This can happen in two ways. One is the intensity method, the other is the duration method. In the intensity method, sound intensity is compared. Which two sounds? Sound that is perceived by the patient when the tuning fork is kept parallel and near the external auditory canal with the sound that the patient perceives when the tuning fork is placed behind the ear on the prominent part of the mastoid bone. So there are two positions of the vibrating tuning fork. Near the external auditory canal parallel to it, and on the bony prominence of the mastoid bone behind the ear. When you place it on the bone, it tests bone conduction. When you place it near the external auditory canal, it tests air conduction. Now, whichever sound is perceived to be louder, that form of conduction is perceived to be more. If the sound on the bone is louder, then bone conduction is more than air conduction. If the sound on the bone is perceived for a longer duration, then again bone conduction is more than air conduction. Now, when bone conduction is more than air conduction, Rini is said to be negative. When air conduction is perceived to be more than bone conduction, Rini is said to be positive. So in this situation, we have something called false negative. So negative means bone conduction more than air conduction, and false means this does not reflect the actual disease scenario. When can this happen? So imagine a scenario where you have placed the tuning fork in front of the or near the external auditory canal, and patient says, I can't hear anything. Then you place it on the mastoid bone and patient says, yes, I can hear. Now this can mean a simple Rini negative, or it can mean Rini false negative. What is Rini false negative? If this particular ear has severe sensorineural hearing loss, when you place the vibrating tuning fork on the mastoid bone, sound is not getting heard by this cochlea. It is getting heard by this cochlea. How? By transcranial transmission of sound. Sound is getting transmitted through the cranium. As I said before, cranium is an excellent medium for sound conduction. So sound is getting transmitted transcranially to the other cochlea. Why is this happening? Because there is severe sensorineural hearing loss in this ear. Patient can't hear practically anything, neither with air conduction nor with bone conduction. But when the vibrations are getting perceived by the patient on this ear, it is moving all the way to the other ear through the cranium, and patient is able to hear with the cochlea of the other side. So this is not true negative Rini, because this cochlea is not hearing it, this cochlea is. This is false negative Rini seen in unilateral severe sensory neural hearing loss. I hope this made sense. If you have any doubts, if you want further clarification, please feel free to mention it in the comment section below. Moving on. Next question we have is OAE shows pass in auditory neuropathy. Next to pass, we have something called false negative. So what does this mean? We have to understand a lot of things here. OAE, it refers to otoacoustic emission. Otoacoustic emission, as the name suggests, some sounds are getting emitted from some part of the ear. What is OAE? It is a screening test for hearing. It is not a diagnostic test. Therefore, OAE does not indicate presence or absence of a disease. All it reflects is pass and fail. Pass most likely means there is no disease, and fail most likely means there is a disease. So that requires further evaluation. Now, in OAE, when does a patient show, what does OAE test? OAE tests normal functioning of the outer hair cells present in the cochlea. Okay, so outer hair cells emit a sound. These sounds are called otoacoustic emission. They can be spontaneous otoacoustic emissions, or they can be evoked otoacoustic emission. Spontaneous otoacoustic emissions really have no clinical significance. Evoked OAE are the ones that are measured in the screening test. This is an objective test. It does not depend upon the response of the patient. Objective tests are tested by machines, whereas subjective tests depend upon both the machine as well as the response of the patient. Okay, so OAE is an objective test where the functioning of the outer hair cells present in the cochlea are tested. If the outer hair cells are functioning normally, then OAE is supposed to show pass, all other factors being normal. But if the pathology is beyond the cochlea, such as in the auditory nerve or maybe somewhere in the brainstem, then OAE will also show pass because the outer hair cells can still function normally. However, if the pathology is in the external auditory canal like wax, OAE will show fail, is likely to show fail because the sound is not reaching the outer hair cells in the cochlea. So you have to understand the sound conduction pathway. Sound in the environment, getting collected by the pinna, moving through the external auditory canal, making the eardrum vibrate, then the ossicles vibrate, then the sound reaches the oval window, goes into the inner ear. That's where the cochlea is. Beyond the cochlea, you have the 8th cranial nerve, and then the entire auditory pathway all the way up to area 41 in auditory cortex. So if the pathology is at the level of the cochlea or distal to the cochlea, like in the external auditory canal or at the tympanic membrane, then there is a possibility that OAE can still come as fail. But if the pathology is beyond the cochlea, in the auditory nerve, like it is there in this condition, OAE is going to show pass. Does that make sense? I hope it does. So otoacoustic emission shows pass in auditory neuropathy because outer hair cells are still functioning in auditory neuropathy, and functioning outer hair cells will usually reflect a pass result in OAE, and this is reflective of a false negative result because disease is present but was not detected by OAE as the disease was present in the auditory nerve. If you require further clarification for this, I'll be happy to make another video just on this topic. So please feel free to reach out in the comment section if you need further clarification. And the final question for today is malignant otitis externa is a misnomer. Now, what does the word misnomer mean? Misnomer is the literal meaning does not reflect the clinical meaning, to keep things simple. Okay? So misnomer is a word where the literal meaning is different from the actual meaning. In this case, malignant otitis externa literally suggests a malignant disease, that is a cancer. However, malignant otitis externa is not a cancer. It is a severe infection of the external ear associated with inflammation and presence of granulation tissue. And typically it is seen in immunocompromised individuals where the main complaint is usually severe pain. It is caused by Pseudomonas aeruginosa. And you can write one or two things about the treatment. It is usually conservative treatment with intravenous antibiotics and maybe a little bit of debridement. So you can talk about the treatment also, but the key thing here, the key point in the explanation is malignant otitis externa is not a cancer. It is an infection and it is associated with immunocompromised individuals. So it is a misnomer. That is a term which is different from its literal meaning. I hope this answer made sense, and I hope you liked this video just like you liked my other Explain Why videos. Thank you so much for watching it. Thank you so much for subscribing to my channel. If there is any improvement that I can make in my videos, please feel free to mention it in the comment section below. All kinds of feedback is welcome. Thank you once again for watching this video. I hope I'll see you again in the next video very, very soon. Take care. Bye-bye. And please don't forget to be awesome.